Okay, welcome everyone. Okay, we are live. I see you guys bringing your questions in already. That's wonderful. We do have a Google form and we have our first question from the Google form here. So make sure that you go ahead and click on the Google form to submit your questions. Unless you're a channel member, you will get priority as a channel member, and super chats get priority as well and don't have to use the form. Otherwise, please use the form, and then that way we can see your question here. Okay, so first question is from Michelle, and she is from Houston, Texas, and she's talking about weaning off of mirtazapine. So when weaning off of mirtazapine because of weight gain only works great, really. Can you add in another medication like trazodone to help offset the withdrawal symptoms, or should you completely wean off of it first before adding a new medication? This is a good question when we're talking about de-prescribing. So the reason she's getting off of this is because of the side effect of weight gain. It has nothing to do with being too sensitive to the medication or having tolerance or, feeling as though the medication has stopped working and now she's having tons of issues. If that were the case, I would say no. However, in this case, she's just wanting to switch basically to something else to help her with sleep and something that does not have the side effect of weight gain. So yes, you can add in something like trazodone. However, you will have to be monitored closely off of mirtazapine. And when you add in the trazodone, it would have to be at a very low dose. Like I would start at 25 milligrams. And then as you're slowly coming off the mirtazapine, you would slowly then increase the trazodone. Now, a good website to have your provider go to would be the switchrx.com. So that would be the website to, let your provider know about. I believe you have to be a provider to sign in. Maybe not. I can't remember now. It's been a while. But switchrx.com will help when you're switching from one antidepressant to another or one antipsychotic to another. It gives you a good guideline on how to do that. Okay. Next question. Let me see. Oh, okay. I don't see the next question on here. Okay. All right. All right. Nope, it says test. Okay. I thought there was a question on this form. Okay. So we'll go over here. Let's see. Should HRT, this is from Erica Hull, should HRT be the first treatment for anxiety at menopause? No. What you want to do at menopause, though I know what you're saying with hormones can be out of whack, what should be the first thing you do is do your labs and then decide what is causing the anxiety. HRT can be a treatment option. First treatment option shouldn't be an antidepressant or an anti-anxiety medication, but sometimes it has to do with dietary deficiencies and things of that nature. So get your labs checked. I have a video on mental health labs, and I do like to look at estrogen, testosterone, progesterone. But also looking for things like B12, folate, vitamin D, your inflammation. Is your gut, are there signs of gut inflammation or gut dysbiosis? Because as you get older, those things also become prominent. And so with HRT, that can have a lot of side effects as well. And so always start with the foundational things, cleaning up your diet, fixing nutritional deficiencies. If there's any signs of gut, dysbiosis or microbiome challenges, fix that gut first. And then actually you'll notice that your hormone levels will go up. Another thing that can cause hormone levels to drop in later life as well is not only the fact of menopause, but your adrenal function, especially if you're in a stressful environment regularly. Adrenal dysfunction can be a problem. And so, and when you have adrenal dysfunction, then your DHEA, your pregnenolone isn't working properly. And those are precursors to all the other hormones. And so you want to make sure you have a provider that is understands hormones in that regards and is looking at the whole picture and not just singularly, your estrogen, testosterone, or progesterone. Okay. All right. Let's see. Good morning. Good morning, Lulu. Okay. Let's see. How does someone on very long-term use of almost 8 milligrams of Xanax and 2 milligrams of Clomipramine daily for almost 20 years get off while being able to function? Good question. The thing with benzodiazepines is that you can get to this point of tolerance and withdrawal. I'm not sure if that's where you're at and that's why you're asking the question, but if you've been on them for 20 years, then I imagine that you may be at this state, especially if you're at 8 milligrams and of Xanax and Clomipramine. That combination in and of itself should not be given from a provider. I hate to say it, but that would be like, malpractice, in my opinion. Those are two very strong, potent benzodiazepines. So that is a whole separate topic. But you would want to start off with the Xanax first because clonazepam has a longer half-life. And you would want to, by rule, decrease by 5 to 10% every 4 to 6 weeks. You can do, if you want to try like a hyperbolic or micro taper, and then go down every day doing like drops, if you want to do it that way as well. There's different methods to do it, but definitely it's not going to be easy. You're going to have to get those medications compounded because you can't get those low dosages at a certain point. So when I say compounded, I'm talking about getting the medications in liquid form. And then also being with a provider, talking to a provider who understands benzodiazepine tapering and withdrawing and can help you. Another thing to think about during this time is, of course, labs. I always go back to the labs and what's going on in the body underneath and making sure you're correcting any deficiencies. Though if you're at this point, you may be very sensitive to a lot of supplements and things of that nature. So if you find deficiencies, really leveraging diet to help to correct those deficiencies. So, okay. Let's see. We have a new question in the Q&A. Let me see if I can pull it up now. I don't know. No, for some reason it's not pulling up for me. Okay. I think I have to refresh every time maybe. Just give me 1 second here. Okay. And is this where we are? Okay. Okay, that's the one I answered, Elias. Okay, hold on. Okay, here we go. Let me get back to the slideshow. I don't know why it's not just pulling up, but that's okay. We'll work with it. Okay. Next question from Elias from Denmark. Hi, Elias. Are tricyclic antidepressants more effective than SSRIs and SNRIs? I am starting on nortriptyline next week because the newer antidepressants have not been effective for my depression. I have done mental health labs and I'm taking supplements for nutrient deficiencies. Okay. Tricyclic more effective than SSRIs and SNRIs. Okay. Tricyclic antidepressants can be considered more effective because you're targeting two separate neurotransmitters. You're targeting serotonin and you're targeting norepinephrine. And when you're targeting norepinephrine, there's a downstream effect to also target dopamine. So you're getting more robust neurotransmitter increases. So yes, tricyclic antidepressants can be, and in many studies show more effectiveness than SSRIs, but you have to be careful with side effects. And that's the main reason why they are not first-line treatments. So just be aware of that. Make sure you're monitoring yourself for side effects, and then also have a greater risk for serotonin syndrome if you're taking other medications that can act on serotonin. So also be aware of that. And I'm glad to hear that you've done your mental health labs and that you're taking your supplements and correcting those nutrient deficiencies, because that's always number one. And hopefully you found some benefit from that. Okay. Let's see for the next question, if I can pull it up. From Erica, I answered that one. Okay, we have one from Tori. How can I continue to improve my mental health without obsessive feelings? I need to change everything about myself. Thank you. Obsessive feelings, or maybe she's referring to, or he's referring to obsessive thoughts. Definitely with therapy, this therapy can be beneficial. And what I mean by that is it takes a lot of practice to work on the thought processes of themselves. Now, it depends on what the obsessive feelings or thoughts are, on how you would work on them. But a lot of it is about seeing if there's any triggers. Sometimes there are triggers to the obsessive thought or feeling, like for instance, feeling unsafe, feeling scared, being in an environment that triggers anxiety, etc. So understanding what the triggers are is first, and then working with the therapist to perhaps give you a little bit of exposure to that trigger, and then work through those obsessive thoughts, what they are, and then perhaps some CBT as well could be beneficial in helping that. So it's not so much changing yourself, it's changing the way you're viewing that situation that's triggering the obsessive thoughts or feelings, and then reframing them. That would be the process of CBT. Sometimes it can be where you need medication, like if it's affecting your life and these obsessive thoughts and feelings consume your life, and it was refreshing last time. I'm not sure why it's not refreshing now. But is that the next one? Okay, yeah. Okay, good morning. This is from Damon, and he's from Quebec in Canada. So hi, Damon. So good morning. Let's embrace the morning light like a canvas of possibility. I am so sorry. I think there's sound now. I'm trying to keep track of all of these different things, and I apologize that I was not audible. So I don't know if you guys heard me. So I will go back to Ismail's question. So he had a question about mirtazapine causing nightmares. So I'll repeat what I said. So with mirtazapine causing nightmares, so some people can be very sensitive to serotonin, and serotonin is your precursor to melatonin. And high levels, meaning too much, so say you don't even have a deficiency, which oftentimes you don't. But so say that's the case, and now you're taking something that's increasing serotonin as well as other neurotransmitters, because mirtazapine is multimodal. But serotonin, some people will have like strange dreams, more vivid dreams. They can more dream recall. So whether or not that translates into nightmares is depending on your subconscious, if you have a history of PTSD, fear, anxiety, etc. And so that's something that can occur. Another thing to consider when you believe medications are causing nightmares is the fact of the stages of sleep. So meaning, when you're in REM sleep, you should then, after REM, go into deep and then light sleep, right? So if you wake up immediately after REM, then you're going to be more aware of your dreams and these so-called nightmares, right? And so wanting to make sure that you keep a sleep journal or sleep diary to document the time you're falling asleep, if you're having any wake up times, like when you're having these nightmares, etc., and making sure you're following good sleep hygiene practices, because it may be because you're not actually going through the full stages of sleep as well. But yes, serotonin in and of itself can lead to these strange dreams, vivid dreams, and for some people, nightmares. So that is something to be cautious of. Okay. Now let me see if I have another one. Okay, so we got sound. Do I have another? Hold on, let me go back to the questions. Okay. And refresh. Okay. Another one from Ismail from Algeria. So he's saying, good morning. I'm not a doctor, by the way. I'm a psychiatric nurse practitioner. I have to always make sure that's clear. But I know in other countries, you guys don't have a role for a psychiatric nurse practitioner. And so I get it. But I just always want to make sure that that's clear, because I never want to be accused of misrepresenting myself, okay? That's a big deal, especially here in the US. So I am a psychiatric nurse practitioner, and yes, I can prescribe medications, and I manage patients with mental health problems. Okay, so my name is Ismail. I'm 28 years old, BMI 36. That's pretty high. I had bipolar 2 rapid cycling, GAD, and chronic insomnia. Since 2 months, I've taken lamotrigine, Symbyax, and mirtazapine. Insomnia has eased. However, I've had nightmares. So, okay, nearly every night. Is it a side effect of mirtazapine? In recent days, my fasting blood sugar is high. Okay, that's important. Maybe because of Symbyax. I fear developing diabetes, which you advised me. Thank you very much. So yes, you had the question about the nightmares, which I explained that. However, this high blood sugar can be a factor too. Why? Because when your blood sugar is spiking, so is insulin and then cortisol as well. And so so that can also be disrupting your sleep response, but also causing a lot of inflammation. And so that can be problematic. Yes, it can be from medications, meaning the medications of themselves, like even mirtazapine. The Symbyax has the olanzapine in it, but they can increase your appetite significantly and lead to something called metabolic syndrome, which can lead to diabetes. And I talk about that in those different videos where metabolic syndrome is a factor, as with olanzapine, which is in Symbyax. So definitely what you want to do, and what studies have shown, is that exercise is going to be very beneficial to help reduce this side effect, as well as monitoring your diet and what you're eating. So if you're having a lot of cravings, especially oftentimes the cravings are going to be for sweets, carbohydrates, and those types of things, to replace it with things such as water, like apples, grapes, things that are going to fill you up because they have a lot of water in them, but not be too hard as far as too many carbs or too many sugars, but still kind of satisfy that sweet craving. So only having available to you in your home healthy foods, because obviously when you have a craving and you have donuts and cookies and chips and snacks in your home, that's what you're going to go to. So you have to throw all that out and replace it with fruits and vegetables and satisfy your cravings that way. So it'll be a less impact on your weight and on this developing of diabetes. Another important thing is protein, and protein is going to help stabilize your blood sugar as well. And so making sure that, for instance, if you're having an apple, perhaps having that with peanut butter, good source of protein. So that way the blood sugar spikes will be less as well. So anytime you're having lots of carbs, making sure you're pairing it with a good source of protein. That's very important for blood sugar stabilization, and that is what I would advise there. So talk to your provider about that. Also getting labs to make sure, oftentimes what I see, especially with GAD, with spikes in blood sugar, may not be related to the medication itself, but could be related to adrenal gland dysfunction just because of the added stressors and the increase in stress. So be aware of that, okay? Let's see, all right. You can still hear, okay, good. All right, I'm not sure if there's another question in here. Let's see, no question, I don't think. Keeping track of the chat here, so thank you. Being forced to CT off high dosages such as 6 to 8 milligrams daily for 20 years of benzos, what can someone do? I think you're saying being forced to taper off of high dosages. You know, find a different provider if you can. I'm not sure where you're located. There are, you know, benzo providers or benzo aware providers that you can, let me put that on blank, I guess, that you can look up, and I can actually, let me see if I can find the link for you and pop it in the chat for the benzo providers. Benzo, let's see. And that way I can put this in the chat for you to find a benzo cooperative provider in your state if you live in the US. So I'm going to pop this link here for you guys so that you can. Oh, what's going on? Oh, I'm trying to. Oh, Lord have mercy. I'll tell you, if it wasn't for the Lord, where would I be? Here we go. Okay. Oh, Nunya, you're from Florida. Okay. Well, there's the Benzo Info doctors site, and so there you can look and see the you know, those in your state. I'm in Florida, and I am a benzo cooperating provider. I think there are a couple others too. So you can go ahead and look there to find someone to work with you, okay? And I'm in the Vero Beach area. There's others in different areas of Florida as well. Okay, refresh. So let me go ahead and look at my other screen. This whole live thing is something. It's very intimidating. So I appreciate you guys being patient with me because I have to refresh and do all this stuff, which I don't know why it's not refreshing on its own. That's very weird. but it is what it is. It's technology, right? Okay, let's see. Um, okay, where was I? Okay, okay, that one I did, right? Yep. And then Shelly. Okay, I think this is the next one. Okay, so next question comes from Shelly. I hope that that is correct. Raul will let me know. Okay. So hi Jezel, was wondering if you can speak on the subject of skills over pills, and the situation where meds are too routinely prescribed, and hence the reason why we end up with our lives so negatively impacted, especially the benzos. Just want to add that therapy used adjunctively with your psychiatric provider, I think, is key to growing and learning. Thank you so much, Shelley, for bringing this to our attention. And this is very important. And as I mentioned earlier to a couple of these, with these questions as I'm answering them, that definitely, you want to leverage skills over pills first. So when I'm talking about skills, I'm talking about things like, the thought process. There was that one question about obsessive thoughts, obsessive feelings. Figure out what those triggers are. Doing the work in therapy to overcome those thoughts, those feelings, those obsessions, and better understand why you're having them. Other skills could be things like leveraging diet and exercise. And so, for instance, I've mentioned in multiple videos about nutritional deficiencies that people have, and they're like subclinical deficiencies, meaning they're not acute. You're not going to find them overtly in the lab, so you're looking for optimal levels, right? But if you're not optimal, then that can cause a lot of problems. That's especially the case with magnesium. So that's why I do the serum magnesium and the RBC magnesium, because that one's hard to detect. But anyhow, leveraging good diet, and oftentimes with our diet, especially when we're experiencing stressors in life, that's just life, right? We're always going to have the spectrum of emotions. So we're always going to have anxiety. We're always going to have, downs that are going to fluctuate, right? We can't just be, not feeling anything like zombies, right? That's not how we operate. We operate based off of emotions, based off how we're reacting in our environment and what's going on. And so understanding how to cope with life stressors is definitely key. And also with diet, instead of using food as a coping mechanism, which a lot of people do, meaning they eat a lot of junk food. We talk about foods as being comfort foods in our society, especially in the US and the standard American diet. And so that's what we really have to take a hold of, because that creates deficiencies, especially if you're drinking lots of sodas, for instance. That's too high in phosphorus, so you're going to deplete magnesium just by doing that. If you have a lot of stress, that HPA axis and that cycle requires lots of magnesium, so you're depleting that. If you're not getting outside because you're working from home, or you're working in an office and you're not getting sunlight, now your vitamin D is probably deficient. And all of these things are required for proper mental health, for proper brain function, overall health, even neurotransmitter function. And so when I say skills versus pills, it's therapy work for sure, but it's also diet and lifestyle changes. So cleaning up the diet, looking at the Mediterranean diet, anti-inflammatory diets. For some people, lots of research on ketogenic diets helping them to overcome mental illness as well. So looking at those things, looking at what works for you, and what will be a lifestyle change, not a diet per se. So you make it part of your lifestyle. That's key. Then another part of lifestyle is exercise. And people will oftentimes, with exercise, not, think that, oh, it's too hard. I can't, because they're envisioning exercise as being like this really, intense workout. When in fact, just moving has been shown to decrease depression and anxiety, meaning just getting up, walking around the block, walking for 10-15 minutes, that's considered exercise, and you're moving. Even cleaning is a form of exercise. So cleaning your house, when vacuuming, mopping, sweeping, wiping things out, all of that stuff, you're moving, that's exercise. So looking at exercise is not something that is so rigid, especially if it's not something you do, and it's not something like you kind of roll your eyes when people say exercise. Try to incorporate other ways of movement in your life. Then when you start to get a little bit healthier, you can start looking at more intense exercise and maybe leveraging something like high intensity interval training and things of that nature, which also have been shown to help with depression and anxiety. But yes, I think that's very important. And I also agree with Shelley that therapy adjunctively is important. Now, she also is mentioning about meds are too routinely prescribed, and hence the reason why we end up with our lives so negatively impacted, especially the benzos. So what she's talking about here is that, so in our society, it's very unfortunate, but when someone comes to a psychiatrist or a psychiatric nurse practitioner like myself, and they're in that like that system of care where, insurance is paying and this, that, and the other, so the provider's kind of forced to do a quick assessment and get you in and out of there. Oftentimes you get slapped with a label, right? Instead of saying, let's look at your diet, let's look at lifestyle, let's do labs, right? Then we just go right to the label. We look at our DSM, we, want to look at symptoms only to check off those boxes and then give you a pill. The problem with that is if you're not correcting the underlying deficiencies or the underlying issue, that pill is not going to be very effective and oftentimes can be detrimental. You can end up with lots of side effects. Maybe if you did labs, you would find out that you have a high toxic burden, and actually giving you something like a psychopharmacologic medication can actually cause inflammation, right? And can cause a negative response, like mast cell activation syndrome, for instance. Some people have that. That means they can't really be on medications. They have to get rid of the inflammation. They have to get rid of the offending agent. Most psychiatric providers are not doing that because they're not taught to do that. Me being an integrative psychiatric provider, there are many others out there as well. So, we do want to look at the whole picture and not just give medications, but in the system of mental health, this is one of the things that is wrong with the system. You get slapped a label and you get put on a medication, and oftentimes, if you're not looking at underlying root causes, over time more gets added to the mix because, well, the SSRI didn't work, so let's do an SNRI. Maybe that partially worked, so let's add an antipsychotic. That stops working, let's add a benzo. That stops working, let's add, et cetera, et cetera, et cetera. And now the person's on 4 or 5 different medications, nothing is working, and they're just having a bunch of side effects that now providers are wanting to add more medications to, instead of looking at the big picture and saying, wait a minute, this person is probably experiencing side effects, and perhaps this label we put on them isn't really the issue. Perhaps the anxiety or the depression is a symptom of another underlying issue. That is always the first question that you should think of. And in fact, I've mentioned this before, but our DSM is not flawed. Our DSM, though many people criticize this, one of the requirements for every single diagnosis that gets ignored is this episode is not attributed to the physiological effects of a substance or another medical condition. We don't rule out the medical conditions. So if your psychiatrist isn't doing labs, isn't looking at underlying root causes and just putting a label on this disease process, like, or the symptoms, right? Then they really haven't followed that book. So though many, disagree with the DSM-5, and I understand why, a lot of it is because they're ignoring ruling out those medical conditions, and that requires a lot of extensive looking into the root causes. So sorry, I went on a tangent there, but that's my soapbox for sure. All right, so let's see if we got another question. Oh, I guess I have to refresh because I was told we do. So let's do that, and we'll get to the next one here in a second. Do, do, do. Alrighty, is this where we are from Matt? Let's see. Yep. Okay. Perfect. So Matt has a question. He's from North Dakota. So hi, Matt. In your clinical experience, what medication works best for treatment of social anxiety disorder? Are there any specific meds, SSRI, SNRI, that you see work best? Okay, so you were present for my soapbox, right? Okay, so looking at root causes first, looking at, thinking of anxiety as a symptom versus a disease. Okay, make sure you do your homework and make sure that there's nothing else going on that could be contributing to that. Oftentimes too, especially social anxiety disorder, this could be a result of fear-based response. So it's something that your brain has it has been wired to. It's like you've trained your brain to be anxious in these settings, and it happens over time for many reasons. And so definitely working with a therapist, especially for social anxiety disorder, is first line treatment. So making sure you're in therapy, you're trying to figure out your triggers, trying to figure out like how this developed, and trying to break that cycle. Definitely that first. Look at your diet, look at your lifestyles, look at, are you sleeping well, etc. All those things are important. And then when it comes to medications, start with SSRIs. That's where you start. Looking at something like for SAD, something like escitalopram can be helpful. And then if that's not effective, going, from there, and then moving to an SNRI if SSRIs are not effective. But I would try a couple SSRIs first before going to SNRIs, just because of increase in side effects, and SSRIs being more well tolerated, with escitalopram being one of the best well tolerated. But sometimes you may need something a little different, like fluoxetine, because you get a little bit of the norepinephrine, dopamine as a downstream effect to some of the serotonin receptor sites that are being blocked, such as 5-HTC. So anyhow, start with SSRIs, but first skills, like I mentioned, looking at your lifestyle, your diet, exercise, sleep, then SSRIs first. Okay. Any more? No. Do we get another one? Let's see. The audio keeps going in and out. I am so sorry. So sorry about that. I hope you were able to hear what I said. Let me see if there's anything I can see on my end with the audio. Okay, let me switch back. Looks like my mic is working now. Okay, I'm going to switch back to this audio, and hopefully it's clearer for you and doesn't go in and out. All right. And I'll keep an eye here if it goes out, because it's hard for me to keep an eye on everything. I only have 2 eyes. Okay. Input on Medeus. Medeus is a type of stimulant medication. It's like an amphetamine mixed salt. I only use it a few times, so I don't really have a lot of input on it. Though what I can say about it is that oftentimes if patients don't do well with like Adderall XR, extended release, or even Vyvanse tends to be one of the best, like the Cadillac of the stimulants, but say you don't respond to that, then they usually will respond to this Medeus. I'm not sure how to pronounce it exactly, but the one thing I don't like about it is the fact that it is branded, and so you have to go through a couple of hoops. If you have insurance. If you don't have insurance, then you're going to have to pay quite a bit out of pocket for it. You may be able to get some discounts on GoodRx for it. But like I said, I don't have too much experience of it because of that, because it's still branded, it's still expensive. The few patients that I've had on it have really liked it, say that it works really well, has a very long half-life, and so oftentimes works really well for those patients who need that longer duration of action. for saying if you're in college or something like that and you just need a longer duration. But like I said, oftentimes cost is a factor and not being able to prescribe it to patients. Oh, thank you, Shelley. Yes, she's saying that exactly, they're not taught about the providers. Yes, that's so true. Um, let's see, new question from Tiffany here. Let me go back to my refresh. Okay. And then, oh, we did that one. Okay. Tiffany from Virginia in the US. So what is your input on Medeas? Oh yeah, I said that already. Any tips on taking it? Oh, tips on taking it. I actually also, I'm glad you added that here to this slide, because I do want to mention something. When it comes to stimulants, especially those working on the amphetamines, the amphetamine salts, there is an issue with when you're taking these medications. First of all, you want to take them in the morning. Best to take them on an empty stomach and just take it down with water. Why? Because citric acid, increasing citric acid in your GI tract, meaning by drinking something like orange juice or lemonade or some teas will have a lot of citric acid in them, can decrease the absorption of it, or speed up the metabolism of it and make it less effective. So that would be my tip on taking it. And that's with any stimulant. That's like your Adderall, Vyvanse as well, that works on the amphetamine and salts, dexedrine, etc. So definitely making sure that you take it on an empty stomach and just take it with water. Also avoiding adding things like coffee and other stimulants, because now you're going to make yourself more prone to side effects. And I'm actually going to be making a video on Vyvanse and Adderall. I have those outlined, so hopefully I'll get them recorded today and get them out to you guys by next week. I'm going to try to do that. But yeah, I'm glad that you added those tips on taking it, because those are important factors to remember with stimulants, especially the amphetamine salts. Okay. Is there any question? Oh, test. What's that? No. Okay. Nothing there, I don't think. All right. Okay, that was Tiffany. Oh, good. You haven't had me cut in and out, so you guys are still hearing me. That's good. Fawn River. I've tried them all. Currently on Medeas, works okay-ish for me, but also have sleeping disorder. I just want generic. Oh, it just went generic. Oh, okay. Well, I didn't know that. That's good. That's good to know. We have another option. Vyvanse also just went generic, by the way. I didn't know about Medeas going generic. That's great. Yeah, we don't get these like alerts or anything. So yeah, we learn from our patients. So that's good. Good to know. I'll double check that too to make sure. And then Betty Oman, what do you think about pregnancy with the new medication Auvelity? You know what? When it comes to pregnancy, Auvelity is the bupropion with the what is it? The NMDA antagonist, the cough syrup stuff, the DM, right? Dextromethorphan. But really, I'm concerned about the bupropion. Seizure risk is high, seizure threshold goes low, and when you're pregnant, you have an increased risk of these types of things because of your nutrient risk, and so that's why you have to be careful with that. And so definitely go ahead and, as far as with pregnancy therapy. I would say, because we can't really say any medication is safe in therapy, safe in pregnancy. And so therefore, no medication is best. However, there are research studies that will say SSRIs, like things like sertraline or Lexapro, are relatively safe, right? But what's relative? So you got to be careful there. Discuss this with your OBGYN, discuss this with your provider. Another thing for yourself, doing your prenatal visits, making sure you're eating, taking your prenatal vitamins and things of that nature. If you're in a deep depression, you're probably not going to take care of yourself. You're probably not going to take care of, the baby. And so that's where they were saying risk. Okay, so we're going to go back to this audio. It looks like you guys can hear me now. But as I was saying with the pregnancy, that definitely discuss it with your OBGYN, discuss it with your primary provider, your psychiatrist, make sure everyone's on board. Therapy first. Of course, no medication is safest. If you have to choose a medication, SSRIs like escitalopram, sertraline have shown a lot of safety data, or have a lot of safety data with pregnancy, but does not mean that it is 100% safe. There's still going to be a risk, so you really have to weigh that out, risk versus benefit. Okay, that's important. Okay, and then I'm going to jump here. Mr. Specimen, I was prescribed Paxil for panic disorder. I have a bit of respect for the side effects at the beginning of therapy. Can you say something about it? Thanks. Yeah, so Paxil for panic disorder. I have a video on Paxil, and I get a little bit of I guess you could say backlash, as far as the fact that I call it the worst antidepressant. When in fact, it works very, very, very well, especially for anxiety, especially for panic disorder. Absolutely. My beef with Paxil is that it has a lot of side effects that he's talking about, especially in the beginning, one of the worst to tolerate. So most anyone who starts Paxil will have like stomach discomfort, dizziness, headaches, nausea. I've had a patient who just vomited on it in the beginning and was not able to tolerate it. So a lot of issues with that. If you're able to get past the first week or two, of course, then it could really be effective for you. But then the other thing about Paxil that no one really talks about is that it's one of the worst of the antidepressants to come off of. And thankfully, they do make it in liquid form, so you can really titrate slowly and all of that. But even though you go through, the titration slowly, and maybe you're doing a 5% reduction each month or whatnot, you will still have side effects. You will still have withdrawals. and they can be very significant withdrawals. So, that's my beef with Paxil. That's why I don't prescribe it unless the person is adamant. Like the only times I prescribe it is they come to me and they say, I've been on Paxil, it worked for me, I want to get back on it. I know in the beginning it's going to be hard, blah, 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 and they want to start it and they understand these risks. But yes, Paxil can be very effective for anxiety, specifically anxiety, panic disorder, and even PTSD to a point, depending on the symptoms of PTSD that you have. How long to wait before you can drink citric acid juice after taking Vyvanse so it stays active? Good question. So 2 hours. You want to give it at least 2 hours in the gastrointestinal, especially Vyvanse, because Vyvanse's metabolism occurs through that membrane of the gastrointestinal tract and through the RBC, through the red blood cells. So there really isn't a lot of liver metabolism going on. So 2 hours minimum, 3 to 4 to be safe if you're a slow digester. But if you didn't take it with food and you just drank it, say with water, then 2 hours should be fine. How can I get off citalopram? Has been on it 6 years and it's hard to get off. 20 milligrams. Been on it for 6 years. Okay. Yes. So like I was saying before, I gave some advice with the benzo. It's the same thing with antidepressants. So especially citalopram, that can be a hard one to come off of. So making 5% reductions, every 4 to 6 weeks. And when you make a reduction, this is with any taper schedule that you do. When you make a reduction and say you have pretty significant withdrawal symptoms in those first couple of weeks, and that's your clue that, like, say you did 4 weeks and then you made the reduction and then you had, some severe withdrawal symptoms, but then they settled down after a couple of weeks. That severe withdrawal symptom, like, response is like your clue. Next time, do 6 weeks before your next drop down. And I always say too that when you have the withdrawal symptoms, stabilize for at least 2 weeks. So make sure you get stable, and then don't do any adjustments to at least 2 to 4 weeks after you get stable. So most people will find stability at about 2 weeks when they do a drop down, and then wait and then go down. But if you have a severe withdrawal symptom, like, when you make that first drop, that's worse than the one previous, then you have to go slower. So it's very individualized. You have to monitor your symptoms. Also, another thing to keep in mind is that you want to, if you haven't already, because oftentimes people who are experiencing this antidepressant quote unquote poop out that they say, like when they stop working, or maybe been on multiple meds, or now you're getting side effects of the medication, want to come off. It's because you've ignored underlying issues, you've ignored root causes. And so making sure that you're assessing for those root causes before even starting the taper. Okay, so that's going to be like definitely number one, and what I like to do, because if you start a taper and then you start having real problems and then you're stuck and you can't find stability on a stage, by that time it's really hard then to now reverse back to looking at root causes, because now you're going to be sensitive to supplements and sensitive to all these different things that can actually help you during your withdrawal process. And that's a mistake a lot of people make. A lot of people, they'll come to me after they're already in this stage of dysregulation from a antidepressant withdrawal and say, help me. And I'm like, okay, we're kind of doing this backwards. We should have done this before you even got on the antidepressant or before you even started your taper. And so things look a little different. It's a lot more challenging, unfortunately, for the person. But so if you haven't started your taper, I would say to start there with diet and make sure that you do your labs, look for root causes. Oftentimes nutrient deficiencies are your number one root causes: vitamin D, B12, folate, maybe you have the MTHFR. Maybe it's inflammation, etc. Oh, we got a subscriber, Luli Kato, subscribe to the channel. So she should be able to start chatting with us. So welcome her. That's awesome. All right, Luli, thank you. And so yeah, so that's my whole soapbox on de-prescribing and coming off of it. And that's the same advice for benzos. It's the same advice for, antidepressants, etc. And also one of the reasons why some people can get off a lot easier than others. It has to do with, these underlying root causes and ruling them out. And my one video on mental health labs touches on a lot of those root causes and the labs that you should do at least first, like the basic labs that everyone should do before getting on psych meds. And then I have another video that talks about the root causes of mental health and why antidepressants don't work. That one will also give you a little bit more detail on what I'm talking about when it comes to these root causes. Okay. Let me go back. Damon, this one? I thought I answered this one. Oh, let me go back. Maybe I need to refresh. Okay. Okay. That's that one, which I am. Oh, Elias, here's a question on light therapy. But is there another one that I missed? No? Okay, let me go back here because I answered this question already on Damon. This was the one where he talks about the Vyvanse and the 30 milligrams being sufficient, and we talked about tips for cognition. We've already gone over this in the beginning, but basically Vyvanse max dose 60 to 70 milligrams depending on your situation, but 30 milligrams could certainly be sufficient. Tips to enhance, get out in sunlight, go for a walk in the morning, get that cortisol awakening response activated, maybe drink some green tea, focus on an anti-inflammatory diet, especially because he has a concussion and there's probably brain inflammation, and lithium orate could also be beneficial, and also definitely omega-3s would be beneficial for someone with a concussion and someone trying to enhance cognition and memory. So talk to your provider about all of that. Elias, what are your thoughts on light therapy for depression? So light therapy, good question. Can be very effective. Lots of studies show that it can be effective, and oftentimes is effective because of something called seasonal affective disorder. So seasonal affective disorder is when you have the depression come like in the winter time. So you live in a place where there's not a lot of light, and we have the daylight savings time, and so we go back and we end up going as far as backwards, as far as not getting enough sunlight, right? So now there's more darkness. And so light therapy is very beneficial. So if you notice your depression is cyclical with the change in daylight savings, with the change in sunlight, or if you're in an area where you're not getting a lot of sunlight, maybe you're in Alaska, etc., then yes, light therapy for depression is way more effective than any other type of depression. So, and they call that, like I said, seasonal affective disorder. And Merle was saying that I wasn't audible while answering that question. Sorry for Damon's question. But I answered it earlier when I was audible. That question came up twice. So I'm hoping that I was audible for it when I went through it the first time. If you need more clarification on that question, Damon, just put it in the chat if you want me to go back through what I went through, but I thought I was audible in the beginning. But if I wasn't, let me know if you want a little more clarification on that question, because I did kind of go through it earlier in the session, like when we were in the beginning when things were working. So anyhow, just let me know if you need me to go through it again, because I will. But yeah, so light therapy can be effective, like I said, for seasonal affective disorder, and those living in areas where you're not exposed to a lot of sunlight. That's where I would definitely leverage light therapy. As far as leveraging it for other types of depression, like a chronic depression, maybe some, you might get some effectiveness, but it's not going to be as robust as someone who has those types of, like the cyclical depression that comes and goes with exposure to light. Okay. Okay, Tess. So, okay, yes, thank you. So, Damon, you do want me to go over the thing. Okay, let me go back. I'll go back over your thing. I didn't realize it was, I'm sorry. Okay, so Damon had a very nice question here that I guess when I answered it earlier, my sound was off, and I gave a really good explanation at that time. So I'll again go through it. So because you have a concussion, you have a lot of traumatic brain injury, which equals a lot of inflammation in the brain. Vyvanse, yes, can be very helpful. A 30 milligram dose of Vyvanse can be sufficient for people. But the thing to note with these stimulants is that the stimulants will actually oftentimes, unfortunately, lead to tolerance. So it's important to take breaks from stimulants, meaning holidays, like on the weekends and things of that nature. So that way you don't develop the tolerance. But if you're developing the tolerance, then you may need to increase the dose if 30 milligrams is no longer effective for you. Max dose is 60 to 70 milligrams. Now, oftentimes that's reserved for adults, with ADHD, and also for binge eating disorder. You go up to 70 milligrams, let's say, if you have that with ADHD. But when we're talking about a concussion and traumatic brain injury and enhancing cognition and memory, we really want to help support the brain and support the brain with healing and decreasing inflammation and improving that. So that's where the omega-3s come in. Omega-3s, lots of research on their effectiveness for treating depression, but also improving cognition and memory. And also with diet, an anti-inflammatory diet can be very beneficial here as well. Now, the other thing I mentioned was getting out in sunlight. So as soon as you wake up, within 30 minutes, and this is for everybody who wants to really utilize, if you're having trouble with sleep or feeling sluggish during the day, get outside within the first 30 minutes, get sunlight, get that sunlight exposure to your eyes. That's going to stimulate the cortisol awakening response, which we want to be active during the day and not at night, okay? So that's key. That helps also with memory, cognition, and focus. Another thing I mentioned was, not to drink like coffee, but like something like green tea, which has a cleaner source of caffeine. And green tea has ECGC, which is an antioxidant, very powerful anti-inflammatory properties as well, which will also help with that traumatic brain injury, as well as with cognition, focus, and memory. So those things are like a must, right? Then looking at the possibility of lithium orotate. And this is something you would want to talk to your provider about. I'm not talking about lithium carbonate, which is the pharmaceutical grade lithium, but I'm talking about, the nutritional lithium. Tons of research on lithium orotate being effective for cognition and memory, specifically with Alzheimer's and dementia. But there are a couple studies with TBI, traumatic brain injury, also helping with depression, reducing suicidal ideation. I mean, there's a ton of literature out there on nutritional lithium. But I want you to talk to your provider about it. That goes with all of these answers to questions. This is all just educational, and you always run everything by your provider first. I'm just giving you like what I would do as a provider in general. But definitely I would look into lithium orotate as well, as a possibility to help. Um, Other nootropics that can be utilized, again, if it's not contraindicated, with your care, could be things like rhodiola. Rhodiola can also help improve cognition, memory, and even dopamine. And oftentimes rhodiola can be combined with stimulants to increase their effectiveness. So we would do that if you're at a max dose or something, or you reach tolerance and you don't want to increase the dose. You could use rhodiola to help further improve the dopamine response and that cognition and memory. Antioxidants, something called OPCs, polyphenols, and things of that nature have also been shown to be beneficial for cognition and memory as well. And there's a bunch of other, tons of nootropics if you go down the nootropic path. But I just find sticking to, the ones that I've seen work, like the rhodiola and, the ECGC, which is green tea, omega-3s, decreasing inflammation. And then there are some OPC products, polyphenol products that we may try. Curcumazole comes to mind with pure encapsulations. That's an OPC product with turmeric, which could also be helpful to reduce inflammation. But I don't like going down the whole supplement rabbit hole, especially if this can be helped with just an anti-inflammatory diet, getting sunlight, etc. Start there before spending tons of money on supplements. Okay. So that's pretty much what I said in a nutshell the first time, and my audio was cut off, so I apologize. All right. God bless you too, Damon, and thank you for your question. Let's see. Awais, which antipsychotic works well with amitriptyline for low self-esteem, depression, anxiety? With this, we want to look at underlying root causes before jumping to an antipsychotic with amitriptyline. So you're thinking of adjuncting. So yeah, definitely looking at root causes first before adjuncting. I wouldn't recommend adjuncting to an antipsychotic with a tricyclic without first looking at root causes. But I think I have a question from Brian in my form, so I'm going to jump to that one. Brian, and there may be others, so let me go back to the form. And I think my audio is still on. Okay. Alrighty. Oh, refresh. Just give me a second. Okay. Where am I? Is it here? Is this the one? Or you said Damon? Okay, here we are. Yep, so we have a couple more questions from Butterflies 2 from Minnesota. My doctor wants me to do a direct switch from Lexapro 7.5 milligrams, to Zoloft 25 milligrams. Been taking Lexapro for 8 months now and finally less anxious, but experience lack of motivation and dull emotions. Thoughts on this? Thank you. Okay. You can do a direct switch from Lexapro 7.5 to sertraline 25, actually. You don't have to do a cross taper with that because it's like the same, pretty much same dose. You're going to from almost lowest dose of Lexapro to lowest dose of sertraline, so shouldn't be an issue with that. However, I want to mention this dull emotions thing. If that's the case, oftentimes this is the serotonin causing this like dulling of emotions, and so again, root causes, I hate to keep drilling down on that, but please, when I see something like this, I'm highly suspicious of perhaps we didn't go through a lot of the root causes, and oftentimes I'm thinking methylfolate problems, methylation problems, vitamin D and B12. When I see this dulling of emotions with serotonin, those are the things that pop up in my mind right off the bat. Hypothyroidism can also, or Hashimoto's thyroiditis, which can lead, like that would be chronic Hashimoto's, can also cause this dulling of emotion thing. But those are the things that pop up in my mind first. If that has been ruled out correctly, and that's not the case, and you're wanting to go the route of psychopharmaceutical drugs, then when we're looking at motivation and the dulling of emotions, you could either switch to something like bupropion, which would be very helpful in that regards, or add a little bit of bupropion. When you add bupropion to either of these medications, you do have to be careful with the inhibition, and so you want to keep the SSRI, either the Lexapro or the Zoloft, at a low dose, because bupropion will inhibit the metabolism of them, more so with sertraline than with Lexapro. So 10 and under as far as milligrams go, and the Zoloft you can go as high as about 100 milligrams, but don't go any higher than that. Because you can go up to 200 as a max with Zoloft. But anyhow, that's something to discuss with your provider about. Now, some people, if you're having, like you mentioned, the anxiety piece, maybe a direct switch to bupropion may not be helpful or work for you, depending on why, like what your anxiety symptoms are, where they're derived from, etc. Because you may get stimulated on going like directly from an SSRI to an NDRI, which is what bupropion is. And so maybe just adding a little bit of bupropion to help with this dulling of motivation and dulling of the emotions can be helpful with that SSRI in place. So you may not have to switch from Lexapro, especially if it's helping your anxiety. Not necessarily. But again, like I said, check for those root causes, please, and make sure that you're also looking at your diet, your lifestyle. Those things are important. Don't shrug them off like many people do because you want a quick fix. Because if that's the case down the road, you're going to end up with a lot of problems, treatment resistance, etc. That's what all of that leads to. So be careful with that. Don't ignore making those lifestyle changes and assessing for root causes. Okay. From Tennessee, 50 milligrams of Prestige for 5+ years. Also 5 milligrams Valium as needed, dysregulated and need help. Well, I wonder, okay, dysregulated. I'm wondering if you're referring to sleep is dysregulated, is mood dysregulated? And if you've been on Prestige for 5+ years, I would imagine you've been on it that long because it's been effective. I have to do a lot of guessing with this question. So if there's some dysregulation, I would point to Valium being the culprit, especially if you've started using Valium more often. The reason being is because benzodiazepines, though, people will say, oh, you're a hater and this, that, and the other, as far as when it comes to benzos, because they help so many people, and I recognize that. But in the long run, oftentimes, especially if you're taking it for a long time, you end up with rebound symptoms, you end up with, this withdrawal, like interdosing withdrawal, which doesn't happen much with Valium because it has the longest half-life when you're looking at benzos. And it's very stable in that regards. But if you've been taking it, like say every day or every night, and now it isn't working, and now you feel dysregulated, that could be the issue. So you have a couple of choices. You can either increase the dose of Valium, or you could, taper off of it to get off of it, and then also look for your underlying root causes. Because I imagine if you've been on Prestige for 5 years and then maybe that stopped working and now you're dysregulated, then we may be also dealing with something where you've ignored root causes, and after some time it kind of just hits you, and then nothing works, and then everything you try kind of backfires on you and does the opposite effect. And when I see that, I start thinking of toxicities. I start thinking of, toxic burden, mast cell activation syndrome, which is a result of a long, heavy toxic burden. When I say toxic burden, I'm talking about things like mold, even Lyme disease can cause something like that. Chemicals, chemical sensitivity, so too much exposure to different pollutants, heavy metals like lead, even too much copper, can be an issue. So there's a lot of things that can lead to this dysregulation, especially when you've been on something for a long time. So say it's like the benzo because you start taking it more regularly and that stopped working. It could be from that, but it could also be because there's a toxic burden going on, an inflammation, an underlying inflammation. So look for those things. Look at my video where I talk about the basic labs for mental health. If you have a provider who understands how to read those labs, then they can see if there's a pattern of a toxic burden going on based off of your CBC with diff and your CMP. Based off of a few markers from those two things, there's a pattern that will show up if you have a high toxic burden that we can be suspicious of, and then do further testing, like look for heavy metals or mold, etc., or even like gut dysbiosis and things like that. But yeah, that's unfortunate when that happens, and that's what Shelley was saying in her question, where she wanted me to talk about skills before pills and all of that. Is that the whole issue lies with this system and not looking at the root causes first, like the DSM to rule out medical conditions. We have to rule out these root causes, and when you're not doing that, you're just being put on a pill. Yeah, it might be effective for some time, but if you're not closing all those holes in the bucket, then you're just putting water in a bucket with holes. Maybe you plugged up one or two of them with a pill, but then over time, it's just, it's never going to get full, and that underlying problem gets worse and worse, and then your bucket's never full because there's too many holes. So you got to be careful with that. Okay. Is there another question from Brian? Here we go. Plans for review of Clomipramine for OCD. Plans. Maybe me, please, review of Clomipramine for OCD. So Clomipramine is a tricyclic antidepressant that is often used for OCD, and certainly I've had that on my list as far as making a video for it. I won't cover it in detail, but that's one of the topics I'm working on for a video. But just to kind of brief you guys on it, very effective, lots of research on treating OCD. It's also known as Anafranil. So yes, can be very effective for the treatment of those symptoms, but lots of side effects. A lot of people can't tolerate it. So oftentimes you take you take either the whole dose at night, or you can split the dose and do like a partial dose, like a small dose in the morning and then a larger dose at night to get the effectiveness, depending on the severity of the OCD itself. But yeah, most people will have to take the dose at night because of sedation being one of the most common side effects. But then there's other side effects: dizziness, headaches, high blood pressure. You're going to have to monitor liver enzymes. Just thinking off the top of my head, cardiac abnormalities. So looking at your heart rate, making sure you're getting a yearly EKG, that it's not affecting your QT interval. Other things like dry mouth, so the anticholinergic effects, so dry mouth, constipation can be a factor. I'm trying to think of what else. I already mentioned the nausea, the dizziness. Maybe urinary retention can be a problem down the road with it. So comes with a lot of side effects, but a lot of people will find benefit with OCD. And as I said before, with skills before pills, it might be something that you can use short term for a few months, while you're in therapy, so that you can work on these skills, figure out your triggers, the thought process behind it, do the CBT for OCD and find a therapist that works specifically with that. And then go ahead and, taper off after you've developed those skills. Then you use those skills as you're tapering off of the Clomipramine. But yeah, that's on my list for video. There's been a few people to ask me for a video on Clomipramine. And I see the chat going off, so let me, okay, good. Let me go over here. Oh, we got a new member, so let's celebrate. We have a new member. And I have a super chat thanks thing. you for a minute. So I want to thank you for becoming a member. That's awesome, Luis. Now, if you're a member and you post a question, we're going to answer it. That's priority. So, and I see you have a question, so let me get right to it. And transition back. All right. Luis, you say, hello, I have bipolar 1 with mixed episodes and rapid cycling with psychotic features. Lithium, 300 milligrams. I got red itchy spots. Oh, could I still take it at a low dose for neuroprotective benefits? Okay. So lithium 300 milligrams is lithium carbonate. Lithium carbonate is pharmaceutical lithium and very high dosing of lithium. So it is possible, and oftentimes this is true, that patients who cannot tolerate lithium carbonate or end up having side effects with lithium carbonate do very well with low dosing of the lithium orate or the nutritional lithium. So yes, you could still take a low dose for neuroprotective benefits as opposed to the lithium 300 milligrams. Another thing about lithium orate that I want to mention here is that because it's low dose, when I say low dose, you can start off, if you want to be cautious, like just 1 milligram, twice a day, and then maybe go to 2 and then 3. Most people will find benefit anywhere between 5 to 10 milligrams. But if you're concerned about how you're going to respond to it, you can always go slow and start off with the 1 milligram. And if you're taking it for mental health, then you certainly want to, be taking it twice a day. If you're just taking it for neuroprotective effects and you're not really needing it for mental health symptoms, like you're trying to treat a depression or even a bipolar, then just once a day would be fine. There is a lot of good research out there. I actually have the book here right next to me because I've been reading it. Nutritional Lithium, this book by Dr. Greenblatt, is very, very, very informative and can definitely guide you in the right direction with nutritional lithium, because there's tons of benefit with it. And I'm also going to drop in the chat a link, a site. Let me see if I can do this. A website for lithium orate that is going to blow your mind. Oh, we got a new subscriber, Grumberlin. Okay. Okay, here it is. So this site here, I'm going to pop it in the chat for you guys. So Dr. Greenblatt is awesome. He's a mentor, and I'm in his Psychiatry Redefined program right now, and it's amazing all the stuff you learn for integrative psychiatry. But he has, I'm sorry, I'm trying to put this in here in the chat. It's hard for me to do it when it's popped out like that. Okay. Here we go. Okay, so that website is his website, but that page right there is all of the compiled research from his book and from, even now current on lithium. And so, so definitely, take a look at that. If you like to go through the research and you want to learn, you have a lot of time to learn about lithium and all of its benefits, that is the website to go to. I think there's a lag in my video, and I hope you guys can still hear me, because it looks like you can, but I think my video feed is frozen. Okay. So I answered that one, and now let me look at, oh, I see another one from Luis. How is the keto diet for bipolar? Okay, keto diet for bipolar, lots of good research. and tons of research on mental health as a whole, especially depression. I want to say there's probably more research on keto diet than there is depression. Um, but Chris Palmer is going to be your resource for the keto diet and its treatment for depression. He's actually treated patients with bipolar with the keto diet and also schizophrenia. He also has a podcast where he talks about, I think it's with Huberman. If you just look Chris Palmer podcast, I'm pretty sure it's with Huberman, like in YouTube. It might be like it's going to be long, like 2 hours or so. But they really go into detail on he has a book, but also his clinic and how he treats mental health symptoms using the keto diet. I'm not an expert in that realm, but I do know that there's tons of research out there and new research every day that is developing. So definitely something to look into and to consider. The other thing I want to mention when it comes to diets and when you're thinking about diets for treating mental health is that you don't want to look at it as a diet, okay, but as a lifestyle. Because if you're going to be using a keto diet, which is a very hard diet to stick to, you have to make sure that it can be consistent with your lifestyle, because if you get out of keto, then there's a possibility that you could end up slipping back into your depression or your bipolar or your schizophrenia, etc. So it has to be something that, like, whichever diet you choose, that's your new lifestyle. So don't look at it as much as a diet but as a lifestyle. Okay. Are there any more questions in the thing here? I don't think, because I think you would have alerted me. So let's move on with the chat. So TC says, hello, I have a question about cortisol levels. Is there a way to find out your cortisol level through lab work? Absolutely. And it's not through blood work. So finding out your cortisol through lab work is going to require actually a salivary sample. And so that means spit. And there's a lot of different tests out there, but you're going to want to do one that looks at the diurnal pattern. So that you get your cortisol awakening response and you see the curve. So meaning instead of just doing a morning cortisol, it's going to have you do the morning, midday, afternoon, evening, and then night. I believe it's 5 samples. And then you're going to get your cortisol curve. And then if you also do, so that's like just a cortisol, diurnal cortisol is that test. Lots of labs do them. And then there's like the Dutch Plus, which is going to look at all the hormones plus the adrenal gland hormones like DHEA, pregnenolone, and that's urine and salivary. So it's going to give you the cortisol awakening response as well as DHEA. Now, you could look at your lab work and look at DHEA, and that is going to give you a clue to if your cortisol is dysregulated, if your DHA is very, very low. Absolutely, that would be a clue cortisol is dysregulated. Also, fasting insulin, that's another blood marker. That would be high. You may also have a high blood sugar, high fasting glucose, hemoglobin A1C could be elevated, triglycerides could be elevated. When you see like that metabolic syndrome pattern, that could be related to high cortisol. And so if you want to kind of dial in on where the cortisol is peaking and you want to know the time, like if you know, to try to treat it, if that's like the main issue going on, then doing the salivary cortisol test could definitely help you to pinpoint where that is. But you have to look at that in the whole big scheme of things, as far as, not just looking at cortisol, but, looking at adrenal function as well. Okay. So Damon, God bless you, Doc. I have to restroom, but God bless you. Thank you. God bless you too. But yes, thank you. Yes, I'm going to be doing the video on Vyvanse and Adderall. I have those two already outlined, ready to go. So hopefully I can record them later today for you and have them up by next week. And you can thank Raul for that, because he's the one who is able to edit the videos as fast as he does and get them to y'all so we can get them in a timely manner. So thank him for all that he does. And Raul is Hyperion. He is managing the chat here for us. So give him a big thank you. And then let's see, golden knowledge on Valium, everything else, grateful. Thank you. Yes, yes. And I'm grateful too. I've found this stuff kind of haphazard in my own practice. Kind of like my background in discovering all of this, because I didn't learn a lot of this stuff in school. Though I love my school. I love EKU. I went to Eastern Kentucky University for my advanced practice nursing, and I love that school. And we did touch on some complementary alternative practices for psychiatry, and we definitely touched on some of this, but not to this whole like underlying root causes. There was talking about medical conditions. We learned about hypo and hyperthyroidism, and we learned about looking at some of these underlying issues, but not to the extent that I've learned now. And so that was always on my radar. And we also did learn the dangers of benzodiazepines, as far as, if you, don't prescribe them, like that was like the warning given to us, because you're going to have problems down the road, but never like a course on like, oh, what happens if someone gets stuck on a benzo, or what happens if someone comes to you and they want to get off their benzo. We were basically taught to follow our prescriber's guide, which is written by Stahl, and he says, that you can just taper, 25%, in a couple days, and then another 25, like, very, very fast, which we know is not the case. But anyhow, I stumbled on this just by listening to my patients in clinical practice. I was kind of enmeshed in that community mental health setting, the insurance-driven psychiatry practice, and had to learn by listening to my patients that there's something going on here, and these people are not getting better, and in fact they're getting worse. And either I'm going to just continue down this path and have a blind eye to everything that's going on here, where we're just like a pill mill and just passing pills to everybody blindly, or I'm going to look into it and figure out that there's a better way. Because I was not okay with that. I was not okay with labeling people treatment resistant and just giving them all the meds possible and making them more ill. I mean, that's all, in fact, what was happening to a lot of the patients that I had seen in the community mental health setting. Granted, I helped a lot as well, but that is where I started questioning things. And then by questioning things, stumbled across this whole integrative psychiatry, Dr. Greenblatt's, information, and a lot of other information out there that there is a better way. And it's just all about educating, you as the patient, and being an advocate, which is why I started the YouTube channel, because medications can be used and I've seen them work, but we shouldn't be stuck on them for life. We should look at underlying root causes, and we should fix those so that people can be free of these medications that can eventually cause harm. So that's my whole soapbox on that. All right. You're welcome. Elaine Bezek. Let me go and okay, let me see the form here. There may be a new question in the form, I'm thinking. My video's been lagging. I'm sorry about that. Okay. Okay, I think this is the next question from Candy. Oh no, that one. Yep, we did get those from him. Okay, yep, I answered those. Okay, so now we're going to answer Candy's question on tapering off of tramadol. And let me just make sure that my thing is working. Okay, yeah. All right, so how to taper off of tramadol, taking 50 milligrams 3 times a day. Doctor said to split one, but it isn't splittable. Any ideas? You know, I haven't had to taper someone off of tramadol. This is a pain medication that has some opiate properties to it. And, you know, when it comes to tapering off of that, I really don't know, except for, you know, using the basics of, you know, when I taper off patients off psychotropic medications and de-prescribe those, that you should, you know, go slow. Ask if there is a way to get to the lowest dose. Is 50 milligrams the lowest dose? Like I said, I don't, you know, ever prescribe tramadol. I'm a psychiatric nurse practitioner, not a primary care, not a pain doc. So, you know, I don't really have experience with prescribing this or taking it or anything like that, or having to taper someone off. But just the basic guidelines of de-prescribing would be to figure out what that lowest dose is of tramadol that you can get access to. Figure out if it's compoundable, meaning like, can you compound it? And if you're able, like he said, to split one of the doses, like say you split, you know, the evening dose to 25, and you have like you can't tolerate that, then consider, you know, going a little slower. With 50 milligrams 3 times a day, that's 150 milligrams total overall. So the most I would cut anyone when I'm de-prescribing would be 10%, which would be 15 milligrams. So if you're cutting you know, more than that and taking, you know, 25 off, that's going to be like a 25% reduction. So, you know, that may or may not be tolerable for some. And the reason I do the 10% at least most, and then some patients need 5% reductions, is because I've seen, especially with psychotropic medications, how you could be very sensitive to the medication, and then be sensitive to like the side effects and the withdrawal that occurs, especially if you drop down too quickly, that your brain can't readapt to that new set point. And so that causes those withdrawals. And I imagine from opiates, you know, you probably feel pretty crappy, maybe flu-like symptoms and things like that. Maybe not as bad as, you know, your SSRIs or benzos, just looking at opiate withdrawal versus, you know, benzo and antidepressant withdrawal. But, you know, definitely, you know, maybe reach out to your doctor about it, mention your concerns, see if there's a lower dose that you can get, and try to cut by the lowest dose possible. And also ask if the medication can be compounded to a lowest dose if you have concerns about sensitivity and withdrawal. Okay. Okay, Tess, is there another question? I thought there was. Why am I seeing that? Oh, no. Hold on. Here. I already answered that, didn't I? Yeah. I answered that question. And that was Candy's question. Is there any other questions on here? I don't see, because then I go to test and then I go to the end. Is there any more? Okay, yep, thank you for redoing the Lithium link and the Lithium website if you had questions about that. And I did answer, I did answer Luis's question about that. And I don't know that there's any others in here. Let me refresh here and see if there's any new ones, because there might be. Sorry, guys. I answered that one. I don't think. Is there a new one? I already did that one. Okay. Yeah. Yeah, so I don't think there aren't any more in the form. I think there was Elaine maybe had a question or something, but I didn't see it um, pop up in the form. Okay. And I may be lagging again with the video and audio. I hope you guys can hear me. I'm gonna double check that again. Sorry, there's lots of things with live. It looks like you guys can still hear me, but my video is lagging, so I apologize for that. But yeah, we don't have any questions, so let me just focus on the chat as we are waiting on. Oh, you know what? I didn't configure that one, so let me go back to my Q&A screen just because I'm go back there. Sorry, guys. Okay, there. We're waiting for questions now coming up from the form. Now, I asked a question about another subject. MMJ, well, benzos and intolerance, especially for sleep. Yeah, you're probably talking about marijuana. Okay, yeah. So Shelly, good question. When it comes to, and that's Lulu Love, which I know is Shelly. I know her, and she asks lots of questions, which is fine, which is good, good. I thank you and appreciate it, and I appreciate your support. She comments a lot, and I appreciate that. So Shelly, when you're talking about marijuana while on benzos and intolerance, especially when it comes for sleep, you've got to be careful with marijuana. It's best to do medical marijuana just so you can get the strains, so that you know what you're getting, right? Because there's so many strains out there, and you can end up with like too many like sativa-based strains where you're now wired and you're more anxious, maybe more paranoid, where you would need something more like indica when it comes to sleep and helping with those problems specifically, as well as CBD. And leveraging CBD more than THC is actually shown to be more beneficial. And so products that have higher contents of CBD is actually better than those with THC because THC is psychoactive and can have very similar consequences as benzodiazepines and even the psychotropic medications, where it may work at first, and a lot of people experience this. This is why I don't like using marijuana for anxiety or any other, mental health symptom, because this is what happens. They use it, it starts working fine. They think, oh yeah, this is cool. My anxiety is great. I'm feeling good. I can sleep. And then the same thing happens, like a rebound symptom, where just like the benzos, it stops working. Now you have a rebound symptomology. You try switching up your brand. You try switching up whatever, your marijuana in general. You try to increase maybe how much you're taking, and you just keep having a reactive syndrome. And that's like when you hit withdrawal tolerance. And that happens with benzos, it happens with antidepressants, it happens with anything that's psychoactive, a psychotropic medication, which, if you're using marijuana as such, is going to have those types of effects. Another thing about marijuana that I don't like is, and this is the THC part. Everything that I'm talking about is THC based. So CBD oils, CBD based, like non-psychoactive, very healing, not going to have these issues. Anything with THC, which oftentimes the even those CBD products that you get out in the market will have some THC, and not all of it is the same. But anyhow, that component creates this dynamic of neuroadaptation, eventually stops working, then you end up with this rebound phenomenon, and now it's hard to get off of it. But the other thing I was going to mention is cyclical vomiting. And cyclical vomiting is nasty. It's a nasty side effect, and it may not happen the first time you take it. It may happen 10 years from now. And then you're like, what the heck? I can't stop vomiting. And you go to the emergency room and you think it's abdominal issues, and it turns out it's your marijuana. It's the THC. It can cause cyclical vomiting. And then when that happens, forget it. Anytime after that, you're going to have a really hard time tolerating marijuana and end up with cyclical vomiting just about every time you take it. So, and that is hard because at that point you have to stop and then you end up very depressed. I mean, people say there's no withdrawal from marijuana. Um, Ask someone who's experienced marijuana withdrawal and they'll tell you that's a lie, because you get severely depressed, severely anxious, and you have all these rebound symptoms that surface after stopping marijuana. So be careful with marijuana. I'm not a proponent. People will argue that with me, and we, go back and forth, whatever. But I've seen the bad side of marijuana all too often, and it's hard to help those people. So, okay. We have a new question received from Power Wagon, so let's get to that question. Onward, upward, here we go. Alrighty. Power Wagon. Is it here? That says yes. Candy. Is this Power Wagon? Okay. I'm guessing it is because that's the newest question on here. So let me get the slideshow on so you guys can see the question and make sure. Okay. So from Nevada, 23 years I was on Xanax and Paxil. My old doctor retired and now I am seeing a psychiatrist. I have PTSD, CHF, and uncontrolled panic attacks. So CHF is chronic congestive heart failure. Okay, I'm 65 years old and I don't have that many good years left. I'm on Clomipramine right now, but my doctor wants me off of that. She took me off SSRIs. Okay, the Clomipramine has not been good for me at all. Very dark urine and diarrhea. My cardiologist has no problem with me going back on Xanax. Okay, here's another thing. This brings up something really good, and I'm glad that you brought this question to all of our attention, because the thing with benzos, especially at this age, like the reason you want to come off of them is because they're causing a problem, right? You reach that rebound reactive symptom, you've been on them for so long, they stop working, so you want to taper off, right? But some patients do fine with the benzos for many years, and it kind of helps them function, especially as you're getting to this older age and you have these uncontrolled panic attacks, et cetera, et cetera. Maybe you've tried coming off of benzos before and it didn't work, and the doctor decided it was best for you to be on something. Now, the reason they probably switched you to clonazepam in the first place was because it's a longer half-life, and with Xanax or alprazolam, very short acting, and oftentimes you end up with interdosing withdrawals. And so in between, like, say you take the Xanax in the morning and then by the time you're ready for the next dose, within 4 hours or so, you're going to have the increased anxiety coming back and this resurfacing of panic attacks. So to help avoid that, they may have switched you to clonazepam because they thought you may have been having that reaction to Xanax. However, patient preference is key. And listening to your patients is also key. And I've had people, and patients, say to me like, look, I understand these risks. I understand that it can cause this rebound, issue. It can cause this tolerance. It can cause this withdrawal. But I feel like I'm tolerating it fine, and I'm fine with where I'm at, and I don't want to change. So you make sure they have the informed consent and they understand the risk. And if they're willing to continue the medication despite the risk, that's the patient choice. However, the provider also, has to be okay with it, in that regard. So finding a provider who's going to be supportive of your decisions. Because as a provider, as a psychiatric nurse practitioner, my role is to do less, no harm. To not want to get you down that path of, being dependent on a Xanax, now having interdosing withdrawals, and now trying to figure out how to get you off of it later on, especially at your age, because it's a lot harder and it's going to be harder on your system. So lots of things to consider here. You have to weigh the risk versus benefit. If your cardiologist is saying, hey, probably be okay to go back on Xanax, then that's perhaps something that you should talk to your psychiatrist about and say, look, I'm having these effects with clonazepam. Um, the dark urine, the diarrhea. The dark urine could be issues with kidney or even liver, and the diarrhea. So make sure you're getting labs done and making seeing how it's affecting you. If that's the case, even Xanax may not be good for you. If you have elevated liver enzymes, you may want to consider lorazepam instead. But if the issue was the interdosing withdrawals and that's why you got put on Clonopin to begin with, and if your liver enzymes are okay, maybe switching to something a little longer like Valium may even be better. But this is something you're going to have to weigh out with your psychiatrist and talk to them about this risk versus benefit, and talk to them about, that you understand the risk. You can pull up, let me do that for you, because another thing that you'd want to do to help the psychiatrist feel a little more comfortable, this is what I do. I have my patients sign an informed consent that is very detailed, and I make sure I read it to them, and each thing they understand, and they sign, initial each thing. Let me see. Informed consent. I should have it in here. I'm sorry. I just want to pull it up so you guys can have it. Benzo. Where is it? Informed consent. Where is it? Okay. Anyhow, let me see if I can pull it up as a link for you guys. Yeah. So here's the printable. Okay. Is this it? Yes, this is it. This goes over everything, and then it has all of the links to the research if your doctor wants to look at it. I'm going to put it in the chat here. Okay, yeah, this is the document. And, okay, yeah. Did it go through? Okay, yeah. So that is the PDF document. You click on that link, it'll take you directly to that PDF document that you can, send to your provider, that you can print out, that you can read and make sure that you understand every single one of those risks, and then say to your doctor, hey, these are the risks that I'm aware of. I'm happy to, I've gone over this, I've signed it. I want to make this part of my file because, I think that going back to Xanax may be the right choice for me. And then it'll be up to your psychiatrist to decide whether or not they want to, go forward with that. And like I said, because, the psychiatrist is probably looking at the angle of do no harm. And especially, as you get into long-term use of benzos, there is an increased risk of harm. But that's just something you're going to have to discuss with them. But sometimes, it is beneficial for some people to continue on with their benzodiazepine. Okay, new question from Kristen here, so let me go there. And then what we're going to do is we're at the 2-hour mark, so I'm going to take this last question from Chris here, and then you guys can put questions back in the form, and I can get to those questions in the next live. We can start with those questions. And the next live is going to be February 24th at 11 a.m. Eastern Standard Time. So make sure to tune in. You could also put the notification on. Once I schedule that, it'll pop up in the live section, and you can put your notification on so you get reminded. Let's see. Oh, was this another question that came up? Okay, so let's do his, and then Oh, there's Elaine. Okay, let's do these last ones that I have on here, okay? So it looks like there's a few questions that I don't want to. Okay, so we're going to do these last few questions and then I'm done. So any questions coming up after right now are going to have to go for next time, okay? But I am going to go through these questions here. And Luis has another question and he's a channel member. So I'm going to do his first, okay? Because that's only fair. Channel members get priority. Okay, so what is the difference between complex PTSD and complex borderline personality disorder and normal types? So complex, I'm going to try to summarize this because this is a lot. And there's actually a really good website that goes over complex PTSD and borderline personality disorder. I'm not sure of a complex borderline personality disorder because borderline personality disorder in and of itself is complex. But there's a lot of enmeshing of the symptoms. And unfortunately, with complex PTSD, especially with complex PTSD, we have some people in the community don't even recognize complex PTSD because it is not in the DSM. It's only PTSD, either acute, like it's happening after after a month, 3 months in that window, or it's chronic, it's continuing for 6 months. But complex PTSD is actually something that happens when you're exposed to multiple traumas, specifically very common in those who experience childhood traumas like neglect, abandonment, etc. And then over time, you end up, having this symptomology that looks like a lot of different diagnoses, especially borderline personality disorder. Oftentimes, patients with complex PTSD get misdiagnosed as borderline personality disorder because of the symptoms of emotional dysregulation, the self-harm, like the non-suicidal self-injury that occurs because you're trying to feel some kind of emotion, you're trying to feel some pain. Also with complex PTSD, another often misdiagnosis is bipolar because of the mood swings and the irritability. So docs will say, it sounds like you're just bipolar, when in fact, if you did a really good history and figured out all of these traumas that this person experienced, it can be explained by that. And really for a true bipolar patient, they have distinct manic episodes. And these mood swings that fluctuate throughout the day, as a result of external stressors and emotions that you're experiencing, that's not a definition of bipolar. That is something like complex PTSD or borderline personality disorder. When you're looking at trying to go through the weeds and differentiate the two, of course, complex PTSD is always going to have that trauma, right, base to it. Also a big component of anxiety, hypervigilance, like some of those like nightmares, flashbacks, all that with PTSD, but more complex, meaning the emotional dysregulation is a factor, severe depression can be a factor, mood swings, like I said, and irritability. Borderline personality disorder isn't necessarily a result of trauma, but it can be because, and oftentimes is, so that's where it gets a little blurred, because borderline personality disorder is a result of abandonment. So feelings of abandonment, meaning like this oftentimes is the case with those who are adopted. Those who are adopted, and they find out they're adopted, or they've always known they were adopted, either or, will have a feeling like, why didn't anyone love me? Why was I adopted? Etc. That can create this borderline quote unquote personality disorder. And I really don't like the diagnosis. I don't like personality disorders as a whole as diagnosing, because a lot of this is behavioral too. And treatment with both of these is therapy. But it's really hard to differentiate the two. It's going to take a deep dive into your history, when the symptoms started, how you're dealing with the emotional stimuli, etc. But they can really look the same, and it's hard to say it all and like to try to sum it up. And perhaps I can do a video on this once I can kind of outline the two complexities, in and of themselves a little differently. because a lot of these symptoms enmesh and are the same. But like I said, main differences is like the continued trauma over time with the complex PTSD, and with borderline personality, it stems from the feelings of abandonment in relationships, oftentimes with the parents, but it can also develop from bad relationships and feeling abandoned in you know those types of relationships, like boyfriend girlfriend, significant other type relationships, that can develop because of that as well. But yeah, definitely worth, I think, a video topic to really pull out the differences between the two a little bit more clearly. But that is definitely a specialty, and you can find therapists who specialize in both PTSD and borderline personality disorder. And therapy is, like I said, is first line treatment for both. So, and for me, another thing I want to mention, I don't like to put labels on things and say you're this, you're that, you're the other. What are the symptoms? What are we treating that? That's where the focus should be, not so much labels, because